Yeah, Rashika, can we start?
Yes, ma'am. Starting. Good evening, everyone, and a very warm welcome to you all. Actually, this presentation has been done before, but since first years were not a part of meeting, it's gonna be. I'll take the first 10 minutes to help them understand what a journal club is, and then the actual presentation will begin. So let me begin with two simple but striking questions that many of us as medicos often face when reading research papers. That is, how do we truly understand what the paper is trying to say beyond the technical words? And how do we judge whether the study is reliable, valid, and relevant to us or not? These are the challenges most of us has faced, and today's Journal Club session is all about finding answers to them. So, I'm Rashika, the Joint Secretary of the Neuron Club and the founding member of Journal Club, SABVMCRI, and I'm delighted to be your host for this event. On behalf of the organizing team, I extend a warm welcome to all the students, participants, and esteemed professors who have joined us today. We're truly honored to have with us our distinguished faculty who will be moderating this session with us. We have Dr. Madhvi Ma'am, Assistant Professor in the Department of Community Medicine, and we also have Dr. Nagesh Sir, Associate Professor in the Department of Pharmacology. We thank you both sincerely for accepting our invitation and for guiding us through this academic session. So now let's begin with a brief introduction to journal clubs. So what is a journal club? It's a structured academic forum where students and faculty meet to critically evaluate research articles, to improve our understanding of the article and develop critical appraisal skills and promote evidence-based practice. So the purpose of the club is to understand how to read the medical literature like a researcher and not just a reader. And to train ourselves to ask, is this study valid? Are these results reliable? How relevant is it to the practice? So, firstly, medical science moves really fast, and journal clubs help us stay updated with the latest research without feeling overwhelmed. Secondly, they build critical appraisal skills. We learn not only to read a paper but to question it. Thirdly, the journal clubs help to bridge the gap between research and clinical practice. Instead of just reading about findings in theory, we think about how they might impact the patient care. They also give us a chance to practice our own presentation and discussion skills, which are crucial for academic and professional growth. And finally, journal clubs encourage collaborative learning. They create a space where students, residents, and faculty can exchange ideas and learn from each other. And a very important point, this skill of critical appraisal doesn't stop in college. Later in your career, once you publish a few papers, you may even be invited as a reviewer to validate other researchers' work before it's published. Journal clubs are stepping stone forward towards this level of expertise. So let's go forward and see how they work. Usually, a person is assigned or volunteers to present the paper, a published paper. They give an overview of the background, the study design, the results, and the conclusions. And the main strength of the club lies in the discussion that follows. Everyone else participates by analyzing the methods, questioning the results, pointing out the strengths and limitations, and sharing their own perspective. The focus is not on simply summarizing the article, but on critically appraising it, really testing whether the study stands up to the scrutiny or not. And finally, the session wraps up with a set of take home messages about the study, about the skills, and about the bridging the gap between the research and the practice. So, moving on to critical appraisal, the most important part, how do you actually do it? So, how it is a systemic evaluation of a paper's validity, results, and relevance. So, using this checklist, we finally understand the validity of study, reliability of results, and its relevancy to practice. For different types of studies, we have different types of guidelines. For observational studies, we have STROBE, which is strengthening the report of observational studies in epidemiology. For randomized control trials, we have CONSORT, which is Consolidated Standard of Reporting Trials. And similarly, for other studies, we have these guidelines. So every time we conduct a JC session, one kind of research study will be evaluated. Today, it is mostly randomized control trials. So, that brings us to the paper for today's journal club discussion. Liraglutide Liraglutide for children 6 to less than 12 years of age with obesity, a randomized controlled trial. This paper will be presented and analyzed by Abhishek, a third year medical student from our college. You'll be very happy to hear that he is one of those very few students from our college who has gained the opportunity to get into an internship in MedSRT. It is a CCMB Hyderabad, if you guys know, microbiological internship that is. And he also has an ICMR approved study going on. So yeah, let's move on to the presentation. Over to you, Abhishek.
Hello, good evening, ma'am. Thank you so much for the introduction. Uh, Now I'd like to present the PPT. Is my screen visible?
Yeah, now it's visible.
Hello, hello. Am I audible, ma'am?
Yes, yes,
Yes.
you're audible. Please go ahead.
Good evening, Rashika ma'am. Good evening, Madhavi ma'am and Nagesh sir. Thank you so much for the session for being here as moderators. Good evening, everybody. I'm Abhishek Rizjan, uh, studying third year MBBS in Sri Atal Bihari Vajpayee Medical College and Research Institute. So the topic for today, the paper today we're going to analyze is liraglutide for children 6 to less than 12-year-olds of age with obesity. This is a randomized trial. So let us start. So this is our topic, and since this is a, RCT, which is randomized controlled trial, we'll be going through a checklist called CONSORT. CONSORT is a short form or acronym for Consolidated Standards of Reporting Trials. We saw in ma'am's PPT that each different type of a study had different set of guidelines. So CONSORT is for RCT. So this has different sections and topics like title, abstract, open science, introduction methods. So we'll be analyzing based on these events. And this is a flow diagram for consort. So yes, consort. So first of all, uh, our paper which we're going to discuss today was published in a very prolific journal. It is called NEJM, New England Journal of Medicine. Okay, so it has an impact factor of 78.5. Okay, so what is an impact factor? First of all, impact factor is a ratio of, see, for suppose there's a journal, it produces around, let's say, thousand articles per year, and out of those 1,000 articles, let's say uh, some amount of number, some amount of articles get cited each year. Okay, so this is the uh, ratio of the number of between the number of articles cited every 2 years. Okay, every 2 years, and the total number of citable articles published. So these are calculated for 2 years. Okay, for example, if an impact factor of 2025 is calculated for the journal. Okay, first of all, impact factors are not for individual articles; they're for an entire journal. So you know different journals, right? Lancet and the one we're doing NEJM. So citations in 2025 to articles published in 2023 and 2024. So 2 years, all the articles that are cited from the journal divided by total articles produced by the journal in those 2 years. So usually all articles have most not usually all journals have an impact factor of 2 to 10. That is the usual one. And some very strong good journals have around 10 to 20. So what is the number here? It is 78.5. That's like really huge. So that means this journal is a top journal. Okay. This, the Lancet, these are all extremely highly ranked journals. So if an article comes in these journals, which it means it has a high impact factor. Impact factor just means it's been cited many times. It does not add to its clinical relevance or anything. It just means it has been cited many times. Okay, and then the lead authors in this one are Claudia K. Fox, Margarita Barrientos Perez, Silva Arsimini. Okay, so there is one concept called ghost writers and guest writers. Okay, ghost writers are people who work a lot, but they're not credited. Okay, so ghostwriters do a lot of work. They write the manuscripts, they collect data and whatnot, and but they're not given enough credit for their work. These are ghostwriters. Guest writers. These are people who are exact opposite of ghostwriters. They don't do a lot of work, but they get extremely high credit. Okay, so some there are some, what is that, um, commercial publishing websites or commercial publishing groups which do this. They, what is that, they hire people to do the work, not give them credit, and what is that, ask people to pay them for credit, okay, for work they have not done. So these are ghostwriters and guest writers. Okay, um, so now let's start with the abstract and keywords of this. Okay, first of all, we are talking about childhood obesity in children. Okay. So, obesity in children.
Abhishek, there is some background noise coming from your mic.
Yes, yes, ma'am. Hello. Yes, ma'am. Is it clear now, ma'am?
Yeah, but there is some noise, background. Okay, continue.
Yes, ma'am. So this article is about childhood obesity in children and how we are treating it with liraglutide. So, uh, what is a type of study? It is an RCT. So here, what we're doing, the main background of this study is the children who developed obesity will become adolescents with obesity, and then they'll become adults with obesity. So adults with obesity is a huge problem, and there are a lot of research studies, and we know that it is a huge problem in India and elsewhere. All, so what we're trying to do is trying to reduce adolescent obesity and childhood obesity. So childhood obesity is the crux we're trying to deal here. Okay, so the children we're defining here is 6 to 12 years of age. We are exactly trying to attempt at that stage. Okay, so what we are doing is usually whenever obesity treatment is given, it is only for adults and mostly above 12 years of age. This never advised. Drug therapy or pharmacotherapy is never advised for children below 12 years. So no drug treatment is given till date. So with this study is trying to start at an initial stage. Okay, so that is what here they're trying, and methods. I will expand on this later. Okay, so this is a summary of whatever this paper is, and then uh, the conclusions is that this is a good start for therapy. Okay, so now let's have a study overview. We use a framework called PIOT framework, PIOT. P refers to population, I for intervention, O for outcomes, and T for time frame. So all of this get defined by the paper. Okay, so P for population. The population we are studying is specific to children 6 to less than 12 years of age with obesity. Okay, uh, now we have to define what is obesity, because different people can have different definitions for obesity. You might think you're fat, but you might not actually be clinically fat. So, and then Tanner stage of 1 to 5, Tanner stage of 1 to, which is pre to post pubertal stage, are also taken. And here we are excluding and including a certain set of people. What is our exclusion criteria? We are excluding children with syndromic obesity. What are some syndromes with obesity? Bidet-Bardal syndrome, and then Prader-Willi syndrome, the one with almond eyes. These are all syndromes with obesity. So we are excluding those. Okay, we are only doing non-syndromic, non-monogenic obesity, and we are not including type 1 diabetes, children who have type 1 diabetes and obesity. So we are only including type 2 diabetes. So a net total of 82 subjects are taken, and these are taken in 23 different sites in 9 different countries. So imagine the scale of this one. Okay, then intervention. What are we giving? We're changing the, what is intervention? Something is going in a straight line. It's going like it is having a normal course. What are you doing to it to change its course? So are you adding a rock, or are you making a slope for it to become easy or harder? That is your intervention. You're making something else other than its normal course. Okay, so here we're giving liraglutide 3 mg QD subcutaneous. QD 4 times a day, SC subcutaneous. Okay, this this is the intervention given, liraglutide. Okay, I'll expand on liraglutide later on. Okay, then outcomes. What are we checking? We are checking for the percentage decrease in BMI. Okay, BMI is body mass index. It is weight by height square. Okay, next is time frame. How long are we doing this study for? 2 weeks of screening. We're screening for 2 weeks. Then we're doing the run in for 12 weeks. And the treatment is taken till 56 weeks. Okay, it's the double blind randomized period. Okay, I'll expand again later. Then follow up for 26 weeks. Okay, 26 weeks, they're not given treatment anymore, and then they're checked. Okay, then this is liraglutide. Liraglutide is a GLP-1 agonist. Okay, what is GLP? GLP is glucagon-like peptide. Okay, so what this does is it increases satiety, it reduces your hunger, okay, and it improves glucose-dependent insulin release. Okay, so if you just increase insulin, it might cause what? Hy Hello, hello.
Yeah, please continue.
Yes, yes, sir. Okay, so if you only increase the insulin, you might be decreasing the glucose content in your blood. So this needs to be a glucose dependent insulin release so that the person does not get into very low blood glucose levels. Okay, so that is GLP-1 agonist, and also why this paper is very very important in now in the present day is because all of you know Ozempic. Ozempic is semaglutide, which is like a sister component of this one. Okay, so that is losing its patent rights in mid March. Okay, so what will happen? It's a generic boom. So the company loses its patent rights. So now it will have a generic boom, and all the Indian companies will make the same drug at a much cheaper price. So this drug will spread like wildfire. A lot of the people will be using it, adults, teenagers, children, all of them will be using it. That's why we need to be aware, and we need to check research papers to know how are the uses, what are the side effects and things. Okay, so now these are liraglutide methodology. First, this is a study design. It is conducted in phase 3. Double blind means both the investigator and the patient does not know which part they are in. Are they in placebo? Are they in interventional? They do not know. Blinding. Okay, this is double blinded. And then dosing protocol. First, we start with 0.6 mg per day. Then it goes on. Okay, escalate. We escalate to different parts. And then they're giving lifestyle co-intervention. They're not only giving drugs. That does not happen in medicine. We give drugs and lifestyle intervention. We ask them to do exercise 60 minutes per day. We ask them to have healthy, better habits. Okay. Then first the screen. Then they're randomized into two groups. Okay, one group where they're given liraglutide, one group where they're given placebo. Placebo means they're not given the drug, they're given some other compound. Okay, and then treatment period 56 weeks of treatment, and then follow up after 26 weeks. Okay, statistical analysis. The sample size is 78 here. Okay, and analysis is used by estimate framework. Okay, first of all, they're using ANCOVA. Okay, ANCOVA is a very specific type of what is that statistical tool which uses regression and ANOVA. Okay, so they use they're trying to use the baseline of COVID. There is a variance in people's baseline weights. Okay, so they're trying to use ANCOVA to stabilize that difference. Okay, next is consort. Okay, these are the consort guidelines, and our paper aligns to most of it. Okay, it has trial registration numbers, participant flow, harms reporting. They have what is it? Adverse effects and serious adverse effects reporting to consort. Okay, they have open science, randomization and blinding, outcomes estimates, funding. Because they're funded by a company, they have a sponsor. They have told that openly. Okay, and allocation concealment. Okay, now what are the gaps or limitations of this paper? They are not focusing on bone mineral density because we're doing this study on children and bone mineral density data is not collected. And then they have not taken data of eating disorders. Are you guys aware of anorexia nervosa, bulimia? Okay, these are disorders, eating disorders. Okay, they have not taken these into consideration and generalizability. Okay, what we're trying to do is we take this paper, it is tested only on a limited number of people. Can we take the data of this limited number of people and generalize it to the entire population? Let's say we take a data about 10 students of the class and we want to draw conclusions about all 150 students of the class because taking data of all 150 students is very difficult. So we try to take a, at least 10 or 15 students who can represent all 150 in a very complete manner. So that here, what is the limitation? They have done in, what did I say, 9 countries, 23 spots, 23 sites, but even then, it is 70% white people. Okay, white as in 70% white people. They have not included uh, a wide variety of other races or countries. Okay, so that is a limitation. Okay, next, change in BMI at week 56. Okay, the children who were taking liraglutide, they had a mean change in BMI of minus 5.8%, which means yes, the drug has worked. Okay, the mean change in BMI in the placebo group. Placebo, they did not take the drug. Okay, they were given make believe other inert substances. Okay, so they had plus 1.6%, which means an increase in BMI. So no drug, it did not work. We're doing this to eliminate any kind of bias. Okay, that is why placebo groups are used. Okay, so estimated difference is minus 7.4. Okay, next, secondary endpoint. So we are not just checking the change in BMI percentage, we're checking body weight change also. Okay, liraglutide and placebo. BMI reduction. Okay, BMI reduction less than 10%. BMI of 95th percentile. These are all other secondary endpoints we are checking. Okay, they're also checking glycemic control, blood pressure, and all the other important things. Okay, this is the chart which shows BMI percentages of 95th percentile from baseline to week 56. Okay, can you see the placebo? The BMI is more or less stable. Okay, some places it increases, whereas in liraglutide we can see that the BMI percentile drops. Okay, liraglutide it has shown that it is helping reduce the BMI. Okay, these are all charts which represent the same thing. Okay, next, adverse effects and safety profile. Okay, liraglutide is known to cause GI disturbances and nausea, vomiting, abdominal discomfort, and other okay side effects. Okay, uh, liraglutide has other brand names also. Okay, it is called Vitago, I think. Okay, and these are the side effects. Side effects need to be immediately reported to the higher authorities so that they can be compensated or the trial can be stopped or they can be informed of the adverse effects. Then now we analyze the study quality. Okay, what are the internal validity and external validity? Here, first of all, we have to appreciate what we have to appreciate here. It is a very good. It is a double blinded. It has a placebo. Okay, they have stratified it into sex and Tanner stages. Okay, so Tanner stages is sexual developmental stages. There are 5 stages in males and females. Okay, then potential sources of bias. Okay, first of all, Novo Nordisk is a company, and that company has sponsored them. If you check what that company produces, they produce high amounts of insulin and other anti-diabetic drugs. So, do you think there could be bias here? Yes, because they're selling that drug. They want research papers that are promoting their drug. So that could be a source of bias. Okay, next, running period is 12 weeks. So 12 weeks, if they're running it in, only people who are compliant or well motivated will take the study. Okay, this so very few people will drop out. So that is called enrichment bias. Okay, and sample size. Even after they're doing it in 9 countries, 23 sites. It is only 82, which is a good number, but it's not a great number. Okay, statistical analysis they used ANCOVA. Okay, type 1 error control they've done. Okay, and clinical implications is that yes, the drug is working. Minus 7.4% BMI difference is clinically meaningful. Okay, so we can use this on severe pediatric obesity patients. Okay, the next. Okay, the clinical implication is that unmet need. Okay, there are no drug usage for below 12 years pediatric age group obesity children. So now this introduces a new idea. Okay, next, external validity and interpretation. What I told before, that 70% of the participants were white, so this limits racial diversity and generalizability. Okay, they're also excluding a lot of other childhood obesity causes like uh, syndromic causes and monogenic obesity and type 1 diabetes. Okay, these are all very important things, but we are excluding them from this study. Okay, then clinical interpretation, that treating obesity at a much younger age can cause very high what is that very high changes. Okay, it can cause weight reduction and they can prevent a lot of uh, obesity associated risks. Okay. Next, registration, funding, and disclosure. Their ethical guidelines. They have followed Declaration of Helsinki, ICH, GCP. GCP is Good Clinical Practices Guidelines, and yes, for all their 9 countries, 23 sites, they've taken ethical clearance at each site separately. So that is good. Okay, and then Data Monitoring Committee has has overseen the safety, and they have openly told that they have been funded by no one order. Okay, so this should not be a conflict of interest. So they've told this could be. So they've told that beforehand. Okay, next, conclusion and clinical implication. So we can conclude that yes, it has clinically significant efficacy. The Liraglutide 3 mg once daily, or okay, combined with lifestyle intervention, resulted in significantly greater reduction in BMI, which we saw was minus 7.4 percentage, and body weight was significantly decreased. Okay, compared to placebo. Okay, safety. The children faced gastrointestinal discomfort like nausea, vomiting, but they were mild to moderate. Okay, serious adverse effects were very infrequent. If they were, they could be pancreatitis, gallbladder disease. Okay, also liraglutide is contraindicated in medullary thyroid carcinoma, men syndrome type 2. Okay, and GI disease. If somebody already has pancreatitis, we could avoid these. Okay, then clinical practice implications. We are trying to do early intervention in these stages. We're trying to find the younger children, there's a phrase, catch them young, treat them young. Okay, and chronic disease management. Which obesity is a very chronic disease. Okay, it can itself harbor a lot of other diseases. So we're trying to solve all of those before it gets out of hand. Okay, monitoring requirements. Clinicians must, okay, they should see how the patient responds individually. Okay, their tolerability, and they should titrate the doses based on the patient. Okay, and if the rare potential side effects which I told, no, pancreatitis, gallbladder diseases, okay, they should treat them for that. Okay, the key takeaways of this paper is that yes, the liraglutide has demonstrated substantial efficacy. Okay, two, safety and tolerability. 80% of the people were shown to have mild to moderate adverse effects. Okay, and adverse effects discontinuation. 11% of participants discontinued because of these adverse effects. Okay, and very rare severe adverse effects have also happened. Chronicity and rebound. BMI and body weight increases across both age groups and treatment after cessation. Okay, clinical practice impact. Before, we never used to treat children less than 12 years for obesity. Okay, we used to wait, or okay, and then treat them later. But now we're trying to treat them before. Then methodological rigor. This trial adheres to modern consort principles. Okay, so yes, this paper is a good one. These are the references. Okay, they've used all these papers as reference. Thank you so much for listening. Thank you, guys. Thank you, ma'am. Thank you, Madhavi. Thank you, Nagaraj.
Yeah. Abhishek, it was a very nice presentation, very elaborately done. And you have not used many slides, and that is actually good. You tried to explain what is actually done in the paper. From this paper, it's no doubt it's a very scientifically sound and robust paper of with respect to analysis. But I have three major problems with this particular paper. One is ethical consideration. So they have mentioned they have they have adhered to the laws of Helsinki and all, but there are four major pillars of your ethics. That is autonomy, beneficence, non-maleficence, and justice. So autonomy is not adhered to because the children are giving assent, and it's the parents who are giving the consent for them to undergo this trial. There can be a parental pressure because of which the children would have participated in this particular trial. That is one. Next is beneficence. We don't know how beneficial this drug is because long-term studies are required, and we have seen from this paper that there are risks involved. Correct. Then non-maleficence. We don't know about the side effects yet. So long-term side effects are yet to be determined. And justice. How are you going to generalize it to the population? It's going to be very expensive, right? So it doesn't serve all the strata of the socioeconomic status of the population. So I think even though they have mentioned rules of Helsinki is adhered to, but ethical consideration is highly questionable in this particular paper. Secondly, the mental health of the children, the psychological aspects. Suppose you are installing the thought of being obese or being something abnormal about the bodies of that particular children. So you're creating some kind of body image issues. So which is not a good practice as per me. Then coming to your, I'm very skeptical about this trend of shifting from preventive to curative. So instead of trying to prevent obesity, you are trying to cure it. And it's being a recent paper, that is a trend right now, which is going on. But we don't know how beneficial it is or where it will take us. But this trend, I'm not very positive about it. And coming to this journal, it's no doubt it's a very gold standard journal, which like they say, if you publish one article, which is equal to some 1,000 articles in other journal, no doubt. But little work for you. Have you seen how many Indian articles are published in this NEJM journal? How many of the Indian authors have published, are being able to publish in this? Just try to work it out. No doubt you will find lot of articles with respect to Indian population, the trials done on Indian population, but the foreign authors are the authors of those particular articles. You will find plenty. Because they'll be mostly funded by the companies and the trials are on the Indian population. So it is published. But as per Indian authors, it is less than 1%. We don't know the reason. And basically the institutes like AIMS, PGI and your CMC, only these colleges are able to publish in this particular journal. Maybe we don't know about what biases or anything. And no doubt the quality also depends. That's all. And as you have mentioned, the critics very well presented. The sample size, ethnic diversity, funded projects, all that you have mentioned. I think it's a very good critical appraisal of the article. And congratulations, it was a good presentation. And Rashika as well, you introduced to the students about the importance of critical appraisal of an article and the hierarchy of this evidence-based evidences. That also was very good. So that's all. If
Hello. Hello.
Yes, sir.
Abhishek, it was a good presentation and the selection of the journal was also very good actually. So as per my thing, I couldn't able to read the full journal because it was in the afternoon. You have sent no. I was in RJHS, I couldn't able to read. But as you have presented, no. So before presentation to analyze any journal, okay, we should know some background about the drug as well as the previous studies, because it is a phase 3A clinical trial, correct? No? So, because you should just go back to phase 2A results and what has happened and what are the side effects have been reported. So, those things you have to just before presenting, because whether they have considered all those adverse effects in this study or they have excluded any other new things. So, those things will come to know by analyzing this. And they have done, there is a many studies on adults actually. So usually it was introduced for the type 2 diabetic mellitus. So later on, it was tried. Now they are using for obesity. So weekly once, I think subcutaneously weekly once in adults. So they are using for obesity. And but side effects is considered. So as we know, it is mainly introduced for diabetic mellitus, and there is a more chances of hypoglycemia. So I don't know whether they have monitored the hypoglycemia or not, because it was not mentioned actually in the side effect. Only gastrointestinal side effects was mentioned, but they could have measured. They could have measured the sugar levels. Correct? No, that is also one more thing what they could have done in this study. And uh, before in obesity, most of the actually they have done. I think they have included. You have mentioned, no, they have included the type 2 diabetic mellitus, something in that.
Excluded, sir.
Huh?
They have excluded type 2, they have included type 1.
No. Type 1 excluded. I think. No, type 1 they can't include because they have to give insulin. They have included type 2. We explained, what I heard.
Yes, sir. Yes, sir.
Type 2 is included, no? So whenever they have included the type 2, they didn't monitor the this thing HbA1c. They didn't mention, no, in the results. Did they mention, Abhishek?
No, sir. No, sir.
No, sir. Sugar levels are not mentioned.
Sugar levels they haven't mentioned. So that
No.
is one drawback they could have taken, because when you are analyzing any journal, so what they could have done better and what they have not done properly. So those things you have to point it out. And uh, regarding remaining, so as I was also thinking about that ethical issues, so as Madam Madhvi Madam has mentioned. So in children, I don't know. So how they have permitted. So because I said they have to take. So and a number of samples also you have mentioned. So it's very less. So that is also one more thing. And overall, it is good presentation. And next time, so my suggestion. So kindly send, suppose any for any moderator, kindly send me one day before, so that we can go through it.
Yes, sir.
And so during presentation, the discussion will be very nice actually.
Yes, sir. Yes.
Mm. And it was good presentation and good initiation. I didn't know actually. So now only I asked Madhvi Madam. So what is it exactly what they are doing? Anta? So it is a good initiation.
Yes, sir.
And
It's a good thing actually.
mm.
We can include postgraduates also if possible. So
Try,
that at
tell
least,
them to join next
yes,
time. So when you are, so you just don't fix the some only UG students. You can post it in the different groups also, in PG
yes,
groups.
yes,
You
yes.
just send me the link. I will share with our PGs also.
Because the presentation level is very good, sir. As a level of PG, sir, they can
Correct.
also join
Correct.
and it will be
Correct.
beneficial for them also.
Everyone, so because sharing knowledge is a good thing actually. So it is beneficial, and you can get the inputs from the PGs also. Hmm? So postgraduate students also, they'll give some inputs and what they have learned. And if there is a good journal, they will also present in the department. Hmm? So it is a good
Sure, sir.
initiation.
Yes,
Very
sir.
good. Thank you for giving me the opportunity.
Yes, sir.
So
Thank you so much.
thank you.
And next time we'll try to include more of an Indian origin study rather than a Western one, because it'll be more compliable. Generalizability will be better if we go through Indian studies.
Yeah, but, oh yeah, that is also there. But this is also a good article, no doubt.
Yeah.
It is
Okay.
now it is a trend actually.
Mm.
This is a trend. So what
Yes,
they are
sir.
doing, I have seen many patients, those who are getting actually in
Mm.
adult patients especially.
Yeah, Ozempic
So,
and all also.
is like without it is like over the counter medication.
Mm. So as I
Uh,
told, the trend is shifting from prevention to all curative.
Prevention. Yes. In
Mm.
children, actually, they have,
Mm.
as you told, no.
Mm.
So should be a preventive
Mm.
measures. They have to analyze more than the
Mm. It's
treatment
kind of
aspect.
indirectly they're promoting the no nodis, they're promoting the drug.
Uh,
Mm.
Now it is in adults. Now they are
Mm.
targeting
The children.
children. But side effect wise, what I have heard is, so there are many side effects are there, but they have not been reported. See, because most of them or whoever the adults usually, so they will come up with later stage. I don't know. So where they will not report because of this drug only. They are getting the adverse
Mm.
effects. Okay. So right.
And that mental health aspect also is not very much taken care of, sir.
Correct, madam.
Because you install children, in children you are obese, you have to lose weight or something. Even though there is a blinding, they'll
Correct.
come to know. So that body image issue will start developing in the adolescent because there's very vulnerable population. So
Mm,
indirectly, there are a lot of mental issues which can cause,
correct.
and this can be the reason for that. So, yes, sir.
Okay, Rashik.
Yeah,
Yeah.
anything,
Any,
Rashid?
Anyone, any questions?
yeah. Any doubts? Please ask. In case you guys get questions later, please text us in the group so that we can ask to the moderators.
Hmm.
So with that, we come to the end of today's General Club session. And on behalf of the Neuron Club, I would like to express a sincere gratitude to ma'am and sir. I want to extend a huge thank you to our moderators for such a balanced discussion. Thank you, Dr. Madhavi ma'am, for your crucial skepticism regarding the curative versus pharmacological approach in a pediatric obesity. And thank you, sir, for mentioning various aspects of side effects which was not mentioned here. It was truly insightful and knowledge-filled session, and we are very thankful to our moderators as well as presenter Abhishek. Thank you, sir. We hope for a
Thank you.
next session in the next month.
Thank
And
you.
anybody who wants to present, please come forward. Please let me know.
Thank you. Thank you
Thank
all.
you. Yeah.
Thank you, ma'am.